Next up are the anatomical structures that are externally located. You need to know their location in the event a patient is scheduled for a procedure regarding them. These types of procedures are scheduled a little less often than the hysterectomies, but still often enough that they show up on the schedule from time to time. So the first one is the vagina and the vaginal vault. The passageway from the cervix to the external environment. It's going to be involved in the prep of the surgical site. It may be included in surgical procedures if pathology exists or if access is ideal. This structure is internally prepped, meaning a sponge is inserted and then withdrawn to cleanse the walls prior to surgery. The vagina is considered dirty. That's important for all procedures scheduled where the vagina is entered. Think about what you learned about bowel technique and be prepared to use it again here if the vagina is entered. Whether it is done so from the vaginal or the abdominal approach, if we are taking the uterus out and part of the uterus is the cervix and the cervix opens into the vagina, are we actually like taking the vagina out during this surgery? No, we're not. So that means that for a little while during the surgery, the vagina is going to be a part of the sterile surgical field. And since it's considered contaminated, just like the inside of bowel is, we're going to be practicing bowel technique. And so it's in situations like this, I'm thankful that the founding fathers of surgical technology named it bowel technique and not vaginal technique, because that would be freaking weird. Okay, the vestibule. This area of the body includes all the structures located within the labia minora. The Bartholin glands reside in the vestibule on either side and are a common site of cyst development, and occasionally those have to be surgically excised. And then the perineum. That is the space located between the posterior vaginal wall and the anus. Occasionally, this area is incised during labor, and it is the particular area of concern during a posterior or rectocele repair. And finally, we're going to address the ovarian cycle, otherwise known as the menstrual cycle. There are 3 phases to the ovarian cycle, which ultimately lasts 28 days. The first 14 days are known as the follicular phase, and that's when the ova begin to develop. The next phase is known as the ovulatory phase, or ovulation, and this lasts anywhere from 16 to 32 hours. And following ovulation, the third cycle is called the luteal phase, in which the remainder of the cycle is spent preparing the endometrial layer to accept a fertilized egg for implantation. In the event the egg is not fertilized, the ova will be passed along with the endometrial lining, and this is what is known as menstruation. Over the next several slides, we're going to focus on diagnostic tests, positioning, prepping, medications, instruments, supplies, and equipment. So there are some surgical procedures listed within the diagnostic tests, which we will cover more during Jigsaw Day. The first thing you've got to know is that the H&P, which stands for history and physical, is obtained by the patient's physician, and it's how a diagnosis is obtained in the first place. That all takes place outside the OR. Most often it's done in the physician's office. It could take place in the ER or up on the floor if indicated, but the physician will be particularly concerned with the patient's menstrual history, their obstetrical history, use of contraceptives or any drugs, whether they're prescribed or not, history of previous infections or STDs, current meds, and their family and social history. All of these variables will hopefully lead to the physician to make a diagnosis or at least schedule a preoperative test to ascertain a diagnosis, and ultimately that diagnosis will either be treated surgically or medicinally, and if it's treated surgically, you get involved. In the category of preoperative tests come several common preoperative screening tests. You'll see on your slide the varieties that exist. Most are performed in the physician's office, but sometimes they do occur in the OR. So can you pick out the ones that occur in the OR? Let's see. Yep, those ones right there. Did you get it right? Good. And it's important to remember that diagnoses that require surgical intervention can wreak havoc on the psychological status of the patient. The most significant situations involve the loss of a baby, the mother's inability to conceive or carry to term, emergency surgery which may affect the future of her ability to conceive, and even her self-image and self-identity. Like breast surgery patients, women can identify themselves based on the presence or absence of anatomical structures, and so as caregivers, we must always practice tact, patience, and empathy with our patients. Also, something to consider, the position these patients will likely be in to accomplish the goal of each procedure is often very immodest. So please be considerate of your patients, because I promise many of them will be thinking about it but not saying anything. Letting them know that you'll keep them safe and protect their privacy as much as possible goes a long ways. One example of how you can protect their privacy is to think about the transfer portion of their care after the procedure is done. You will soon experience the desire for the OR to be a very efficient, well-oiled machine, and in doing so, the OR staff often brings the patient cart in the moment the dressings are on, and this helps facilitate an efficient patient transfer off the OR bed and OR turnover. But you can protect your GYN patient by not letting anyone bring that patient cart in your OR while her legs are still up in stirrups. This next slide covers considerations the OR team must make during the perioperative phase of the procedure. There's kind of a lot to consider, so it might take a little while. You might want to push pause, and you also might want to get an extra piece of paper. Okay. So first off is the position of the surgical patient. Depending on how the anatomy is to be accessed, the patient is going to be in supine or lithotomy, and that determination will be made based on the scheduled procedure, and you will definitely be expected to know what to anticipate. So for example, if the procedure is scheduled as a vaginal hysterectomy, you know your patient will be in the lithotomy position and draped accordingly. Another important factor to consider is your knowledge of critical sterile anatomy and semi-critical clean anatomy, otherwise known as dirty, and how it affects your supplies and instruments. So just like bowel surgery, the contents of the patient are clean to them, but some structures aren't as clean as others. The vagina and vaginal wall are the structures of importance here because they're a natural orifice. Next, you know how the patient is positioned. You have to know where you will be. And oftentimes the position of the scrub tech is somewhat awkward during lithotomy position procedures. And so you might be asking yourself, well, why are we doing this position anyway? I mean, it's awkward for me, it's awkward for her. Blech, sounds awful. Well, the anatomy is much more forgiving if accessed vaginally, and the healing time is much faster, and that also helps with post-operative comfort. So since we're all about the patient, we're going to do it this way. Keep in mind what you know about sterile technique. If your surgeon is sitting on a stool and you have to pass an instrument or suture, think about where the surgeon is sterile. Where are you sterile? What will you pass over each and every time? You and the surgeon are still sterile in the same place, mid-chest to table height. That means when the surgeon's shoulders are at your chest, their shoulders are not sterile, even though you are. Another thing, their lap will be right about table height, but their lap is not sterile. You know the lap was lower than table height when the person got gowned. So think about this very critically when you are passing instruments and supplies during GYN procedures. And when it comes to skin prep and draping, the patient's almost always prepped both vaginally, which is termed down below, and abdominally. You might experience this prep being performed simultaneously by two people, but that is not the best practice. Best practice is for the below prep to be complete before beginning the above prep. Whether two people do it or not is beside the point. The most important thing to remember is the prep solution from the vaginal portion is not clean like the prep from the abdominal portion. And so the down below prep is always supposed to be done first to prevent splattering. As for draping, you need to know the patient's position and the appropriate manner in which to expose the necessary structures. Sometimes drapes can be inventive, which can be fun. It can also be a little tricky. So use the pictures to guide you through the process and model the person that you're draping with. Oftentimes they'll know what they're doing, and so you can mirror them. The instruments in GYN and obstetrics can range from delicate, like surgery on the fallopian tubes, to heavy, like what we use to clamp a uterine ligament, and some of them are even super duper sharp, like a tenaculum that grasps the cervix. We own several examples, and I'm going to bring them to the classroom for you, and you'll get to pass them and handle them and look at them and take pictures and all that good stuff. The same principles regarding patient safety apply. Always count when a cavity is being closed, and be mindful of your use of sponges to prevent sponge retention. The equipment and supplies you will see will vary depending on whether the procedure is being performed open, laparoscopic, transcervically, or transvaginally. Your book actually is a bit confusing on this part, and so I will be sure to address this in class. You will need to apply the knowledge you've gained from lessons regarding open procedures and your MIS unit to this specialty. As a surgical technologist, you will be expected to know the equipment needed for each particular scheduled procedure. So obviously, if a patient's going to be in lithotomy, you have to know that they're going to need stirrups. And you have to know that if this is an MIS procedure, you have to have the MIS equipment. So surgical techs are always thinking. We're always preparing our OR, and we are always anticipating what our surgeon needs. It's what we do. The medical drugs used in the OBGYN surgical patient include a few new drugs to you. So we're going to go over those real quick. The first one I want you to know is oxytocin. Its alternate name is Pitocin, and it's used to enhance uterine contractions during labor or postpartum to deliver the placenta. It's also commonly used during D&C procedures in which there has been an incomplete abortion and the surgeon needs the patient to have contractions after the procedure to ensure hemostasis. Methergin is a drug that is often administered IM. Do you remember what that stands for? And this drug enhances uterine contractions and controls uterine bleeding. It is often refrigerated and is requested in more of a emergent fashion. So like the patient is showing signs of hemorrhage after delivery or incomplete abortion, and they'll call for Methergin and have it injected IM. Pitressin sounds like Pitocin if you're not listening carefully, but it's not the same thing. Pitressin's other name is vasopressin, and it's used to constrict blood vessels, very similar to the way epinephrine is used in local anesthetics. Oftentimes, this drug is diluted with injectable saline, but there's no anesthetic agent present. I've personally seen it injected into the cervix during vaginal procedures or in the fallopian tube during ectopic pregnancy removal. Lugol's solution and Moncell's solution are often used during colposcopy. Pitressin, not Pitocin. Awesome. Okay. There. Lugol's solution is a very concentrated iodine and is used to stain the cervical tissue to see if there is abnormal tissue present. The tissue that does not stain is considered abnormal and is then biopsied. This process of staining the cervix and taking a biopsy of abnormal tissue is formally known as Schiller's test. After the biopsy is taken, the tissue tends to bleed, and Moncell's solution is a concoction that can be applied to the cervix to help with hemostasis. Your book indicates that Moncell's is also used for staining, but it's actually a follow-up solution to help with cervical hemostasis. I've even seen Moncell's get applied to a totally healthy cervix that just bled a lot after the tenaculum was removed from a transcervical procedure. So Moncell's is for hemostasis. And methylene blue. This is another drug that can be mixed with saline to create a blue fluid. This fluid can be infused into the uterus and subsequently into the fallopian tubes in a retrograde fashion. Because you know the fallopian tubes are not connected to the ovaries, if we infuse dilute methylene blue into the uterus via the cervix, and it's flowing retrograde, which means backwards, and in the event that the fallopian tubes are patent, what can you expect to see either in the abdomen or on the screen if you're MIS? What do you think you'll see? Think about that. And finally, sutures. Your book does a great job detailing suture usage on page 565. Note that almost every single structure has absorbable suture used on it, and that's because these tissues heal rapidly, and as such, they are most often completely healed by the time the suture dissolves approximately 6 weeks after use.